Hi, everyone. Good morning, good afternoon, good evening, wherever you are. And thank you very much for joining us today on this session on reaching zero-dose children remote rural settings. This session is recorded in French and in English, and we'll share the recordings and the slides by email with everyone who registered. This will be made available on the TechNet 21 website and on the TechNet 21 YouTube channels. This will also be shared with the Zero Dose Children Community of Practice. This webinar is also interpreted into French. To listen to the French, the session in French, please use the globe at the bottom of the window and click on the globe, and I think you should read interpretation and select Français, French. I'll say it in French for our Francophone colleagues. Pour écouter cette session en français, veuillez cliquer sur le globe qui se trouve en bas de votre fenêtre Zoom, sélectionnez donc sur interprétation, sélectionnez la langue français pour pouvoir avoir l'interprétation dans la langue que vous souhaitez. Please also ask your questions during the presentation. To do so, use the Q&A box. There's a Q&A box also available from the bottom of the window. You can use also the chat to introduce yourself, and I'm really happy to see that we have already quite a lot of people who started to introduce themselves. Hi, everyone from Mali, Mongolia, Nigeria, and so on. And you can also use the chat box to contact me if you have any technical issue. If you have struggled with the connection with the sound or anything, don't hesitate to use the chat box, and I'll try to assist you as much as I can. Thank you very much for this, for being here, and I hope you enjoy this session. I'll give the floor to Samir. Samir.
Welcome, everyone. My name is Samir Soda. I work here at WHO headquarters, and I want to welcome you all to our second session in the Zero Dose webinar series. Today's session is on reaching zero-dose children in remote rural settings. First, I want to welcome our esteemed colleagues who are speaking today. We have Sangwe Clovis from Chai in Cameroon, who will be talking about their experiences in identifying zero-dose children in Cameroon. Then we will have Mukhtar ABDI Shube, the EPI manager from Somalia, as well as Farid from the WHO Somalia office, who will be speaking about their experience in reaching drought-affected communities in Somalia. And then we'll conclude with Lisa Ut from JSI, who will share the experiences there on reaching rural and nomadic populations in Ethiopia. But before getting started, I want to just give a quick overview about zero dose. Next slide, please. Next slide. Thank you. So I thought after last week, based on some of the questions we received, it'd be good to just do a quick overview that I think would answer some of the questions we were getting in the chat. So the zero-dose strategy, why is this important? Well, the objective is to identify and regularly reach children that aren't receiving any vaccination through routine services. So those are the unimmunized children that we often call zero-dose now. And this is an important agenda because this is our entry point to achieving immunization equity. And the question we frequently get all the time is, well, how do we measure it and how do we follow the zero-dose children moving forward? Well, at a global and national level, we have a proxy indicator that we're using, which is lack of DTP1. So using that indicator, we can calculate the number of zero-dose children by taking our DTP1 coverage. So say, for example, if you have 80% coverage, you just subtract that from 100 and multiply that proportion by your population of surviving infants. So if you have 80% DTP1 coverage, you would then take the 20% and multiply it by your denominator of surviving infants. So that's the basic formula. The only thing that might vary is what's your source of data on DTP1. At global and national level, we will likely use WUNIC data, but you can also use survey data as well. And for surviving infants, what's the source of information you have there? And so for at global level, we're using UN population estimates. But the important thing to remember, again, is that this is an equity agenda. So we'll often refer to zero-dose communities. And what that basically means is these are communities with a large proportion of zero-dose children. They are essentially our neglected and marginalized populations. So these communities tend to be clustered in particular settings, those being remote rural, urban poor settings, and communities that are also affected by conflict. And that is the reason and rationale why in this webinar series, we have a specific webinar on each of these settings, today being remote rural, last week being conflict affected, and in a couple of weeks, we'll have one on urban immunization as well. And in all of these settings, they all are faced by gender-related barriers as well. And in fact, the Zero Dose Community Practice, we did have webinars about the gender issue as well. That was done in June. And those webinars you can find on the Zero Dose Community Practice website. Next slide, please. The Zero Dose Community Practice is basically an additional resource for you, but specifically on zero dose related issues. So it's intended to be a place where we can form a little bit of a community, a network to share our experiences and our learnings related to zero dose. On that website, we have been posting webinars as well. So ones that have been recorded from previously, so including the one on gender, you can find there as well. If you haven't joined, we invite you to join that as well. So at this point, next slide, I'd like to get started, and I'd like to invite Sangwe Clovis to share his experience from Cameroon. Next slide, thank you. Over to you, Sangwe.
Hi, thank you. I'm happy to present on the, a cost-effective approach to map clusters of zero-dose children in Cameroon using QGIS analysis. Next slide, please. So I'll talk a little bit about the case for action, objectives, methodology, results, and the key considerations for the future. Next slide. So in 2019, Clinton Health Access Initiative, in collaboration with Cameroon Expanded Program on Immunization, carried out a survey in 6 urban districts and 1 rural district to identify under-immunized children. Over 1,000 zero-dose children were found in these city slums and archipelagos rural district. This implied that there may be many more similar mixed communities in Cameroon. However, considering the limited health resources in the country, there was a resounding need to identify and prioritize communities for high impact action. Next slide. So we have 3 key objectives. The first is to improve the identification of herd areas with clusters of zero-dose children trapped in mixed communities using composite scores. In Cameroon, herd areas are administrative level 4 units. And the second objective was to gain insights on characteristics of herd areas with mixed communities. And thirdly, to support Cameroon EPI to prioritize herd areas to reach zero-dose children. Next slide, please. So traditionally, the head counting approach that we would have used requires or may have required over $1 million to identify and prioritize health areas with zero-dose clusters. That is why we adopted a 3-step approach. The first was to generate a score that can be used as a proxy for the probability of finding zero-dose children in a community using QGIS. The second, to identify and rank 100 health areas with mixed communities based on high impact criteria. And the third, to prioritize and characterize 20 health areas. To generate a composite score, we used an iterative approach with Cameroon EPI to adopt 5 indicators and ascribe weight to each. So we had as our first indicator, high proportion of unvaccinated children with TPT1. This was a proxy to finding zero-dose children. At least this was based on the zero-dose definition by Gavi. And then also we looked at hard-to-reach settlements in rural and urban settings. In the rural setting, we considered that a community or settlement that is beyond 5 kilometers from the nearest vaccinating facility has a higher chance of finding or of being a mixed community. This was based on the fact that in Cameroon, when you have a community that is within 5-kilometer radius from a vaccinating facility, the community benefits from fixed vaccination sessions, and between 5 and 10 kilometers, they benefit from outreach sessions, and beyond 10 kilometers, they benefit from mobile strategies. So that is why we adopted the 15 kilometers. And for urban setting, we used 1 kilometer. And the reason is we realize the issue at urban settings is not entirely about distance, but a question of means to get to these facilities. So for instance, a kilometer in Cameroon could cost about 50 cents, which may be costly for a family that lives below the poverty line. So we also looked at number of slums in the health area as one of the indicators. Next slide, please. So this is an illustration of how we identified hard-to-reach communities. First, we did a localization of vaccinating health facilities. Next, we did an estimation of 15-kilometer perimeter around the health facilities, and then superimposed the catchment area on the location of the houses, and then identified the areas of dwellings that were beyond 15 kilometers. So next slide, please. Thank you. So this is an illustration of how we generated the composite score. First image, we have in pink an administrative unit that has a low DPT1 coverage. And then in the second image, you have the blue with hard to reach areas. The darker the shade, the more difficult the access. And then lastly, we have the result of combining these two findings. Here we have in purple, the most likely administrative unit to have multiple zero-dose children. This sort of analysis was done using QGIS. Next slide. So we had a very interesting result. The first thing was we found that there are zero-dose children in every region in Cameroon. But we also realized that there were some regions that had more clusters of zero-dose children. So you have the northern regions, the east, and the southwest region. So here, where you have white shades of administrative units, those are areas with the lowest or with very low probability of finding zero-dose children, while administrative units with pink or darker shades, those are areas with higher probability of finding zero-dose children. Because of this interesting finding, we decided to have a little bit of in-depth understanding of what these communities truly are. So we conducted an in-depth interview with vaccine managers at operational levels. The first thing is we prioritized 20 health areas, and in these 20 health areas, which is administrative level 4, we found that there were 520 communities or villages, and about half of these villages were not covered by the closest or nearest health facility. We also found that 2/3 did not have functional cold chain equipment, and 80% had inadequate health workforce with less than 3 nurses to cover even communities that were even up to 50 kilometers away from the health facilities. About half were enclaved and poorly accessible, and more than half did not have electricity supply and mobile network signals. This obviously explains why they are underserved and why we call them mixed communities today. Next slide, please. So because of the pilot work that we did, we had a couple of lessons that we learned. which we want to share. The first is we think that to do this kind of analysis, we had to include some for urban settings in order to have good proxies for zero dose. It was interesting. It would have been better if we included socioeconomic factors, transportation costs to nearest facility, time to nearest facility, and also consider slums and new settlements in all the major cities in Cameroon. We also had a lot of difficulties in identifying the location of health facilities with immunization services. It required lots of manual merging of information. So we think that for the future, the generation of a master facility list or ID will save a lot of time. And then we also realized that it could have been very, very helpful if we used more detailed human-centered design approaches or behavioral social drivers approaches to characterize mixed communities to better understand drivers of zero dose. I mean, including data on availability and distribution of cold chain equipment and human resources in the mapping process will help in reorienting the intervention design. I'm happy to say that Cleansing Health Access Initiative is currently working with the expanded program of immunization to carry out a more extensive identification process using these key considerations that I've listed for the future. So, next slide. Thank you for your kind attention.
Thank you so much, Sangwe. At this point, I'd like to move over to our next speakers. This would be Mukhtar ABDI Shube, the PA manager from Somalia, and Mohammed Farid from the WHO Somalia office. Over to you now.
Well, thank you very much. Good afternoon, good morning, colleagues. So I'm Mukhtar Abdi. I'm the National EPI Program Manager, Somali Federal Ministry of Health. So I and Dr. Farid will be taking us through accessing and vaccinating drought affected communities in Somalia. Next, please. So the country is, next, please. Next slide. Okay, good. So the country is facing multiple challenges in which improving the health system, coupled by currently facing droughts, conflict, and also disease outbreaks. Additionally, so we have also climate change, also had impact to the country and resulted rapid urbanization, food insecurity, and also increased poverty. For the last 3 decades, country faced conflicts, civil war, in which led a disruption of livelihood activities, a restriction on also trade, and also humanitarian access. Despite all these, country fragility situation also has worsened by the COVID-19 outbreak and setback improving trend of the last couple of years regarding health services delivery. Additionally, currently more than 13,000 measles cases has been reported throughout the country. Next, please. Coming to the current situation of the drought in Somalia, we were facing drought, also natural disaster occurred in Somalia frequently, and recently the country was hit by drought due to the slim and bitter rainy season for the 4th consecutive year. Now, almost 55% of Somali is already affected by severe drought, which is 7.8 million people have been affected by the severe drought since July. And also, more than 1 million people are displaced from their home due to the severe drought and also the conflict happening in the country. So since January to June, the admission rate also of severe malnourished children increased by 48% compared to the previous year. Next, please. So now I also give an welcome to Farid to take us through the remaining slides. Over to Farid, please.
Thank you, Mukhtar. Good afternoon, colleagues. So in addition to Mukhtar's comments about the situation in Somalia, Somalia is also facing CBDPV2 outbreak since 2017. There is ongoing outbreak of cholera in addition to COVID-19 pandemic. So to cope with the situation, and as the health system is fragile, country Ministry of Health, Federal Ministry of Health, with State Ministry of Health, with the support of partners, decided to go for integrated outreach teams in these drought-affected districts. So 101 integrated outreach teams are deployed in 39 drought-affected districts. The package was discussed, the service package for these integrated teams. In addition to routine immunization, as per the government policy, the team is also supporting the community with distribution of ORS, vitamin A, folic acid, zinc tablets, and they are also giving COVID-19 vaccination to the community. Some basic consultation are also provided in this outreach by these outreach teams. It is also important to mention that to link these outreach teams, outreach services with the community, more than 200,000 community health workers are deployed in these drought-affected districts. Next slide, please. So, as an outcome of this integrated outreach teams deployment, starting in March till August, more than 57,900 zero-dose children were identified and vaccinated. Because of the drought, community from inaccessible districts are also moving outside of those districts, and this is a good opportunity to vaccinate them. So BCG was also provided. Close to 32,000 doses are children vaccinated, received BCG vaccine. Penta 3 is 47, are close to 48,000. IPV is another important vaccine here in Somalia because some children are paralyzed during this year because of CBDPV2. So more than 74,000 children received IPV. And MCV measles vaccine is also provided. More than 90,000 children received measles vaccine, and close to 22,000 pregnant ladies also received TD second dose. So the main the impact of the outreach teams is a result of the intervention. The main component was selection of appropriate team members in those districts. So sometimes it's difficult to select people from local community. So that was a challenge, and then team overcome this challenge. Micro planning and deployment of team in appropriate places. So that was another important component to be considered. And then data management, we also facilitated data management and ensure supplies to that areas. Next slide, please. In addition to drought-affected districts, country ministry also deployed teams in 12 low-performing districts in different states like Galmudug, Mirshabelle, and Banadir administration to also provide vaccination to the people, because some of the people are moving to different districts, not necessarily to go to IDPs camps. So 125 teams were deployed for 16 days to work. They were working 16 days in a month for 3 rounds. So in total, more than 2,000 children received BCG, 4,000 Penta 1, close to 2,300 Penta 3, 3,600 IPV, and 1,926 children received measles vaccine. So the picture is showing of the vaccination of COVID-19 and also the situation the team is working. It is in one of the IDP camp. They are vaccinating adults against COVID-19. Next slide, please. Yeah. So about adult vaccination, countries also facing challenges to improve COVID-19 vaccination, but in the last month, there was some acceleration. And so far, 18.8% are fully vaccinated in the country, and more than 5.1 million doses have been administered. 55% of total vaccinated are male. In initial days, only 28% were female, so that is also considered for improvement. And now that vaccination of women is also improving. OCV vaccination was another component by API team. So in 9 districts, more than 1 million received, 1 million people received OCV vaccine, 2 doses of OCV vaccine. We are also gathering, collecting data from the field through electronic tool, which is recently introduced, and that is a new experience team is learning from the experience from the COVID-19 response activities. Next slide, please. So, as I mentioned about Mukhtar mentioned about the measles cases, this year the red line is showing measles cases of 2022, and it is coming down because of the intervention. Team is struggling to have the impact of interventions. More than 1.2 million children of 6 to 59 months age received additional dose of measles in addition to those I mentioned in my previous slides. So this is the last slide from Somalia. I will stop here. Over.
Thank you. Can we have next slide, please? So now I'd like to ask Lisa from JSI to share their experiences in Ethiopia. Over to you, Lisa.
Yes, thank you. Hi, everyone. I'm Lisa Oud. I'm a senior technical officer working with JSI, and I'm excited to present to you today on what works to reach remote, rural remote and nomadic communities. And this is from a decade of learning from JSI's Universal Immunization through Improving Family Health Services project in Ethiopia. Next slide, please. So first, let me give a bit of context on the situation in Ethiopia. Ethiopia is home to a very large number of both zero-dose and under-immunized children. In the latest DHS, only 44% of children had received all of their vaccinations. And with regards to zero-dose, Ethiopia has a duplicative problem. So the highest numbers of zero-dose children are living in remote rural areas, but the highest percentage of children are living in these nomadic areas and nomadic communities, which are wide expanses of land, smaller populations, smaller communities, and also equally difficult to reach. Next slide. So I wanted to provide a brief overview for you all of the context in Ethiopia, the UI-FHS project, and the Reaching Every District Using Quality Improvement Tools approach that we've developed and has been implemented in Ethiopia. So we have a video, so I'll just ask Adriana to please press play.
Achieving equity in healthcare means access for everyone, regardless of who they are or where they live. But when it comes to immunization, inequity persists. Advances made in immunization over decades have plateaued globally, leaving millions of children susceptible to vaccine-preventable disease. The gap is widening in Ethiopia, which ranks 6th in the world for the number of children without any vaccination. Remote, rural, and nomadic communities are particularly vulnerable because resources and access to quality healthcare are limited. To increase immunization equity, JSI and the Ministry of Health designed Red QI, an approach that uses quality improvement tools to strengthen the country's national strategy, reaching every district. At facilities in hard-to-reach places, healthcare workers engaged clan heads and community leaders in immunization microplanning. They asked them to join quality improvement teams to leverage their knowledge of local communities to solve problems. Together, they drew catchment maps and identified underserved communities to determine where and when to immunize, ultimately mobilizing communities to seek services. QITs helped institutionalize the practice of tracing children who missed immunizations, an effort that increased at facilities over time. For the first time, facilities conducted headcounts of target populations, so they knew exactly how many children needed to be reached. Healthcare workers were routinely coached on the job and provided easy-to-understand problem-solving tools. Skills retention and performance among healthcare workers increased, improving their ability to plan and manage their facilities' immunization services. Because of a decade of success, the Ministry of Health incorporated Red QI practices into its national guidance for immunization programs. The Red QI approach is a powerful way to increase immunization equity and close the gap so that all children around the world can be protected from vaccine-preventable disease. Learn more.
Thanks, Adriana. So that just provided a nice overview of the project and the work. So next slide, yeah. So I wanted to say, our approach in Ethiopia was really to strengthen and operationalize the Reaching Every District strategy by integrating quality improvement processes and tools so that each of the 5 components of RED could actually be operational. We commonly find in countries that one piece of RED is operational, but not all 5 collectively. And we really need that in order to reach these communities, these zero-dose and under-immunized communities. So I won't spend a lot of time on this slide, but just to say we incorporated QI processes and tools into each of these different components. So that's what those bullets are there. And I know we'll share the slides out, so hopefully there's more time to look at that. So I want to spend, next slide, please, most of the time really talking about strategies that work to reach zero-dose and under-immunized children. And what we found is in Ethiopia, as I know in many of the other countries, Cameroon, Somalia, et cetera, these communities have really limited access to the health system. Therefore, it's critical from the start to link communities with the health system. And so we implemented a co-creation process to design catchment area maps with community members and health workers collectively, discuss target populations and ideal locations and timing for immunization services during microplanning. We then continued to nurture the engagement between the health facility and the community, engaging community members in identifying those barriers and also enablers to vaccine uptake, designing localized solutions to these issues, and then working with these same communities to mobilize their community members for immunization sessions, to help with defaulter tracking, and to really build that accountability for the health system. In addition, we work closely with district administration, presenting the district with data and evidence on these issues in an effort to create that buy-in and obtain local resourcing to be able to implement activities. In these communities, we really found that it was critical to build that demand for services, but then be able to meet that demand with high quality services. Next slide. Second, I can't stress enough how critical it was to design and implement a mix of services, both outreach and mobile, to reach these communities. I've been told countless times from different health workers, we know where these populations are. We just don't have the money, the time, the resources, the incentives to reach them. We did an analysis of the strategies that were co-designed by the communities and the health workers, and 51% of those sessions that were put forward were for outreach or mobile sessions, targeting nearly 50% of the population. So our work then needed to focus on co-designing a plan to reach those populations, building the capacity of health workers to then implement that plan, and then also engaging non-health stakeholders, district administration, to be able to resource that plan. Because a plan is only a good plan if you're able to actually implement it and monitor that plan as well. Next slide. So we've touched upon this a bit, that it really was important to build these quality improvement teams for health workers and community members together to come and look at and address both supply and demand side services, issues with services. We tried as much as possible to utilize existing community structures so that you're really building within the systems that exist, and use this for collective decision-making around identifying bottlenecks, determining local solutions, and then monitoring the process of those interventions. Next slide, please. We also invested in a multifaceted capacity strengthening approach to really focus on improving the quality of services, of programming and services. If we're working really hard to generate demand in these communities, we have to ensure that the health workforce is able to provide high quality services to these communities. And as we all know, training alone is not sufficient to build and sustain capacity. Retention from training, even the best, practice-based training needs to be reinforced by mentoring or on-job training. In these districts where we were working, capacity of healthcare workers was often low, turnover was high. So there really was a need to support a system of capacity building that over the longer term to ensure that these services would continue for these communities. And I'll say it's not just about capacity building for health workers. It's about ensuring that the system really is supporting those health workers. They have the tools, they have the resources, the supportive supervision, et cetera, to do their jobs really well. Next slide. Lastly, there really was a need to provide technical assistance at all levels of the health system and to focus at each level of the health system. To reach these populations, we found that we needed to work, of course, at the community level and to collect evidence to then present to the national level of what works. So we had serologic evidence from our initial 3 districts that showed immunological protection from tetanus as a proxy of DPT significantly increased in those 3 districts from 2013 to 2016. And this really helped to create buy-in for the approach and led to institutionalization of the Red QI approach in national level guidelines and strategies. And we found that these guidelines and strategies at national and regional level were really necessary for health workers at the community level to do their work. With everything that health workers are required to do, building in these activities into their work that are then reinforced by their supervisors was really important. Health workers have so many different jobs. If we're asking them to do things that their health workers aren't monitoring or asking them to do, they're not going to get done. And so we really did focus our efforts on strengthening management at the regional level, at the district level, and then supporting efforts to help sustain this programming from community through national level. Next slide. So as we continue to strategize on how best to reach zero-dose and under-immunized communities, key critical areas are sustained financing for community engagement in the health system. Really, we advocate for the micro-planning process and working on quality improvement teams or community connections that connect health workers and community members, as this really ensures that services are programmed to meet the needs of the target populations and also strengthens that community health worker engagement. We also have to recognize that it just costs more to reach some of these populations. And so advocacy and financing is really needed at all different levels. And we continue to advocate for innovation around the use of data, capacity building, and really opportunities to strengthen primary healthcare for all levels. Next slide. So that's the end of this presentation. It was difficult to summarize 10 years of work in 10 minutes, but so if you are interested, we have a how-to guide for country level implementers and then a 4-part course to supplement that guide as well. And lots of different resources and tools, job aids, etc. for use. So thank you very much for your time today.
Thank you so much, Lisa. I'd like to thank all of our speakers today. First, Sangwe Clovis from Chai in Cameroon, who shared with us the innovative approaches to trying to identify zero-dose children. And then Mukhtar ABDI Shube from Somalia, as well as Mohammed Farid, sharing their experience in reaching drought-affected communities through integrated approaches. And finally, Lisa Ut, just from JSI just now, sharing their experience with implementing the Red QI, which is basically a holistic, a true implementation fully of RED with human-centered approaches as well. So I would like to open it up for questions at this point in time, and to remind all of you that you can enter your questions in the Q&A tab at the bottom of your screen. And we've already been receiving several questions, so I'd like to start asking some of them already. First, I'd like to ask Sangwe, lots of interest in your presentation. One question that has come up a couple of times was, did you have any challenges with the data quality? Was this all based on administrative data, your analysis, or how did you address the data quality issues that you might find in Cameroon?
Great question. Thank you very much for that question. Of course, we had issues with data quality, but this is one thing that we noticed. The first is mixed communities, that's excluding conflict areas and nomadic population, but every other mixed community is a community that is underserved and has consistently missed out on not just vaccination services, but every other healthcare services. So when you look at the DPT coverage in, say, 2009, it's going to be almost the same thing in 2013, 2019, and 2020. So even though we had this issue of data quality, we decided to use DHIS tool, which is widely acceptable and available. And we had to pick a date, this was 2019, where we had a good completeness of data. So at least we were assured that the data quality was good and was informative with our analysis. Plus, when we went down to the field to do, we prioritized some 20 health areas, and we did micro planning sessions with them. We worked with them to review their data. We also had community members involved in this discussion to have a sort of validation if what we have aligns with the reality on ground. So yeah, thank you.
Thank you, Sangwe. And this actually overlaps with a question that was addressed to me also in the chat about when I talked about the definition or the proxy indicator of DTP1, and they were asking if this is a set methodology or if there's room for other approaches. And my answer was that DTP1 is going to be the proxy indicator we're following at global level to monitor progress on the zero-dose agenda. And it has, however, limitations when we apply it operationally at subnational level because of some of those data quality issues. And to your point, that is why we need to triangulate with other sources of information. And we totally welcome any innovative methodologies that try to identify those zero-dose communities. So we're not totally tied into DTP1 when you get to the local level. We actually want you to think outside the box at that point in time. Next question is addressed to our speakers from Somalia, to Mukhtar and Mohammed. There was a question about how did you address the challenges in the communities that were having security issues or were in conflict affected areas? How were they able to deliver vaccination in those communities?
Thank you. Yes, it is very important and relevant question. In fact, I mentioned in the chat that we engage teams from the local community in consultation with the community elders. So somehow they are providing venues for the services, and they are also providing some protection, although it is not 100% protected. But still, it is good to engage community during selection of teams and also during deployment the teams for services. So that is the only way, and now we are banking on it. Otherwise, it is very difficult to work in Somalia because of the security issues. Every day we are hearing some bomb blast and attacks, unfortunately. So I hope I answered the question. Over.
Thank you, Mohammed. Next question is back to you, Lisa. There was a question that was asked, what was the biggest challenge in implementing the Red QI strategy?
Oh, that's a great question. Can't get my feet. Okay. That's a great question. I think one of the most challenging pieces, I will say, is we utilized a QI process called PDSA cycles, Plan, Do, Study, Act cycles. And it really is an approach that's been used at clinical level for a long time. But application really of this approach at community level, there are some studies around it, but it's not been used widely. We had a really good opportunity of working with communities and healthcare workers around the Plan, Do part. They loved some of the tools, the fishbone analysis and other root cause tools, but the part of studying, of rigorous kind of studying of the intervention, so they would locally come up with an idea to address a problem, and then having the health workers themselves monitor that as we would think about it as a kind of a global research institution. That was challenging. So the health workers talked to the communities and said, well, this approach is working, so we're just going to keep doing it, rather than having it be really based in data. So I think that was something that we spent a lot of time working on, was trying to really help build local use of data. What data is available? How can health workers use the data that they have to really understand and measure whether or not what they're implementing is working?
Thank you, Elisa. Next question, back to Sangwe and the Cameroon experience. Multiple people were extremely interested in all of your innovative approaches to try to identify the zero-dose children, zero-dose communities. But a few people also asking, how has that been used moving forward? How has that data fed into the program since that time? If you can share that experience.
Thank you very much, and thanks again for the question. It was very revealing. It was nothing like we expected. So since we were working in collaboration with the Cameroon Expanded Program on Immunization, we developed an evidence-based strategic plan on how we can progressively reach this community. So this is what happened at strategic level. We also planned a pilot intervention in which we grouped the communities into 3 different groups. You have the non-crisis zone, you had the crisis zone, you had non-crisis zone that needed infrastructural change, and those that just needed more of capacity building. And then we selected 20 health areas, and we started the pilot program already, which we should be able to publish the outcome soon. And at operational level, we noticed that during their micro-planning sessions for vaccinations, they intentionally or unintentionally leave out these communities that are missed communities. So the result of this finding was very interesting, because everyone, they had access to it, and they could see communities where they needed to focus on. And also they included, because we did a couple of micro-planning sessions with them, they included this to be like a routine to include these communities when carrying out my.
So I think your screen has frozen. It's either you or me. I'm going to assume Sangwe.
Yeah, I think we lost him actually.
Okay,
he's still here.
Okay, so when his connection's better, he can finish his thought. But in the meantime, let me jump over back to Somalia and the question that was asked there. And I'm actually going to combine 2 questions into one here. So the question was, to what degree do you think offering an integrated package of services increased demand for immunization, and separately your ability to reach zero-dose children? The second part I'm going to add in there is you also had slides about adult vaccination as well, and COVID vaccine. And so my supplementary question there is, how did that affect demand as well for the children, for childhood immunization? So that question is regarding Somalia for Mukhtar Mohammed.
Okay, thank you for the question. Yes, so integrated approach helped us to reach more than 57,000 zero-dose children. It is first time that country is reaching zero-dose children, and as of June, there are only looking at broader aspects, there are only 18,000 zero-dose children for this year. So previously, country was missing 149,000 children every year, starting 2019. So this is the impact of integrated services. And then adding COVID-19 vaccination to the services also helped in improving routine immunization. Country also had experience of deploying many teams in different districts last year. They were providing both vaccination, COVID-19 with routine immunization. And for 1 million doses of COVID-19 administered, the zero-dose children at that time were, I think, country reached more than 77,000 zero-dose children last year for 1 million doses. So we can just triangulate these things. And it really helps when we have integrated services like provision of ORS and also vitamin A, and country is facing measles and also cholera outbreaks. So that is also helping. In long run, we can assess the impact of these interventions, looking at morbidity and mortality during this time. Over.
Thank you, Mohammed. The next question, I think, could go to all three of you. I will start with you, Lisa, because you'd be next on my list, but I think I would ask all three of you to answer. It's an interesting question about how a lot of these interventions have been funded by external donors. And so what's our thinking about how to get this to be sustainable moving forward, domestically financed, and any thoughts on how any of these strategies and approaches could have more country ownership moving forward? So first to Lisa, then I'll go to Sangwe, and then back to Somalia at the end.
Yeah, that's such a great question. And it's something that we thought about with UI-FHS really from its conception, of really trying to integrate anything that we were doing within the existing health system and health infrastructure. And so really having to, a couple of different things, make sure that you're really not adding activities outside of the health system. And then it really is that need to, we found, really demonstrate that it was working and get those activities included into national level guidance and guidelines so that those processes can be implemented as part of national level. Certainly, there are going to be gaps in funding. We found this, it takes a lot of money to implement mobile service delivery, for example, in these communities. And part of that process was then advocacy around financing through other means. So, for example, can there be financing through Gavi full portfolio planning, or are there other donors who want to take on certain aspects of this work? And so it really was a process that had to include several different components, really working within the existing system, demonstrating what works, building that into national level policies and guidance, and then continue to work with Ministry of Health to secure financing. It's a multi-step process, I would say, for us. Thanks.
And Sangwe, what are your thoughts on this?
Thank you. I think the issue with mixed communities is quite complex. It's very expensive. And so the approaches that we employ in Cameroon aligns fully with system priorities. What I think at least Cameroon or most countries that have similar contexts like Cameroon needs to focus on is leveraging the World Health Organization 6 pillars of health to come up with strategies at a community level that closes some of these system gaps. For instance, from the presentation I did, there are communities where the main challenge has to do with distance. And so providing transport to the closest facility could mean getting vaccines to the last mile, just as simple as that. So I think since we are not creating something out of the system, we're just focusing on what the system is already doing, and we're strengthening it at the operational level. It should be financed in the long run by the state. Thank you.
And back to you, Mohammed Mukhtar, same question about your thoughts about what we need to do to have all of these innovations and approaches become sustainable and country owned.
Okay, thank you very much for raising this question. So I think for Somalia, sustainability is very something important, because we want to sustain the services. Every year we will have newborn children, so all these, they will also need and require vaccinations. So what we have done so far is the integration was a good strategy approach that helped the country to reach more children. Now, in the COVID-19 outbreak, so the country has experienced in raising funds locally, especially domestic resource, which help in COVID-19 outbreak response. So, procuring oxygen plants through domestic fund was what we have seen locally. But the country situation financially is very limited, and now difficult also to pay all these costs. But the country is dependent to donor support, and we looking forward the reform of the finance and also the improvement of health services can also bring to the attention of thinking the sustainability of this. But now we are more dependent to donor, and we are also mobilizing local and domestic resource to at least contribute the health services. So this is the what we can share today. But the government is committed to stand for it and advocate more in sustaining the health services through the country. Thanks. Maybe Farid, if you want to add more to that, please welcome.
No, thank you, Mukhtar. You covered it.
And I would like to especially thank you, Mukhtar, for participating today, because of all our speakers, you were actually the one person speaking from the Ministry of Health, and we deeply appreciate your insights and perspective in all of this today. We're nearing the end of the hour. I would like to just summarize my take-home points from all these presentations. You know, I think what we learned today is that for remote rural populations, there's still many challenges we've had for 40 years and have not fully tackled. But these presentations have showed that there are strategies that can help us move the agenda forward. You know, you have from the presentation from Cameroon, you know, the use of innovation and digital technologies to help us find these populations. But it was also very clear from the presentation that you need to have a very thoughtful approach in terms of how you use those technologies, such as how we define the cutoff points of accessibility. From the Somalia presentation, I thought was extremely insightful on how much we can accomplish with integrated strategies and approaches. And it wasn't just, you know, integrated with other vaccines, but also, you know, across the life course. So there was integration with nutrition, integration with adult vaccination, that helps achieve more with a smaller amount of resources that we're dealing with these days. And then, of course, from Ethiopia and the JSI presentation, the Red QI approach, just basically reminding us that Red is a multi-pronged strategy. It's not just one arm of it, that we need to do all components of it to be successful. It's a holistic approach, and it's an iterative approach to constantly go back and try to iteratively improve things as we move forward. I think lessons for all of us moving forward. And I want to thank all of the speakers again for very informative discussion today. Thank you so much, everyone, for participating. Alex, I turn it back over to you for any other aspects you want to close on.
Thank you, Samir. Thank you, everyone, for this really fantastic presentation. We're going to share the slides and the recordings with everyone. So this should be sent by Monday or Tuesday, the latest. And we hope that you are able to join us next week for the next session, and which is about human resources for mixed communities. So same day and same time. Thank you very much, everyone, and I wish you all a very pleasant day or rest of the day. Thank you.